Here it is, one more week, and we are ready to go inside EMS. I am your host, Chris Cebollero, and with me always is the man of the hour, too sweet to be sour. The ladies know he's the man with the power.
How's it going, Dr. Cebollero?
I am doing well. Thank you very much.
Good,
Yes,
man. That's good. That's
I
good.
completed
Finish your
my doctorate.
PhD.
My doctorate. Well, there is a difference. I don't have a PhD. I have a doctorate. So
Okay.
there is a difference, and a lot of people don't realize the difference. So for a PhD, you can create new content. For a doctorate, it shows that you know how to research the current content.
Uh-huh.
So a lot of people think that they're synonymous. They're really not. So
So it's not piled higher and deeper. It's just a doctorate.
that's right. So I'm a little bit, it's just a dung. So it's just that pile. But thank you for recognizing that, and thank you for your support. I mean, because over the months, there have been times when I've had to cancel your recording with you and
Yeah.
had to do work, and so I appreciate you being, helping me to get to the end of the goal. So part of the doctorate, so maybe part of that last E is you. So thank you very much.
Awesome, man. Awesome.
Yeah.
What are we doing today?
So again, as we talk about things that are really going to be helpful, I think today it's all about the word toxidrome. And Kelly
Mhm.
Grayson, when we think about toxidromes, when do we ever talk about them in EMS except when we're in class and except when we're in
Yeah.
school? And now when we start to think about the importance of them in recognizing the symptoms that we're seeing, it really is paramount. But before we get started, I think with anything, we start off with a great definition. Define toxidrome for the audience.
Well, it's a constellation, a pattern of symptoms that point to a specific type of toxin. It's the clinical presentation, the signs and symptoms and presentation of exposure to a specific type of toxin. And those are unique to the toxin, and they differ between classes of drugs.
And I think that that's one of the things. So now when we start to think about, I used to say all the time, and I think it's still true, Kelly, that paramedics and EMTs are the ultimate detective of the body. And when
Yeah.
you think about a toxidrome being a pattern of symptoms that points specifically to a type of poisoning, we got to be able to know what those symptoms look like, what those patterns look like. And there are five big toxidromes that we should know. And give us number one.
Number one is the anticholinergic toxidrome. It's the class of anticholinergic drugs, tricyclic antidepressants, atropine, diphenhydramine, which commonly used and actually overdosed on quite a bit. The toxidrome is hot as a hare, dry as a bone, red as a beet, blind as a bat, and mad as a hatter. These are the things that present with a anticholinergic overdose. I had always, for many years, I'd heard that mad as a hatter, and I was like, why? And that's from Alice in Wonderland. Why are hatters mad?
Mhm.
Do you know why hatters were mad?
I don't.
Back in the day, hat makers used mercury
Oh.
as an agent to help cure and shape those hats. And so mad as a hatter were people who were mentally unbalanced from mercury intoxication.
Yeah, I didn't know that. One of the other things that when we think about anticholinergic toxidromes, Kelly, you talked about all those key signs, but you also want to look at some of those outward signs as well: tachycardia, dry skin, dilated
Yeah.
pupils, urinary retention, hallucinations, seizures. But one of the things that you mentioned was diphenhydramine. And why is diphenhydramine, and we seem to want to give it all the time, right? But why is diphenhydramine a bigger problem than people realize?
Because it's over the counter in many things. Quite a few. I mean, you can take Benadryl, whose active ingredient is diphenhydramine, but so many different cold medicines and flu medicines and allergy medicines have diphenhydramine or some other type of antihistamine in it. And it's in so many over-the-counter remedies that people often don't realize how much of it they're getting. The same thing with Tylenol.
Yeah.
But in this specific case, lots and lots of over-the-counter medications have some form of antihistamines in it, and Benadryl, diphenhydramine probably being the most common. People get it more than they think.
So, okay, good. Well, let's go to number two then. What's on number two on the list of toxidromes?
It's our cholinergic toxidrome, the other one, and that's organophosphate poisonings, nerve agents, pesticides, that sort of thing. Not as common, but it is. And when we think about our training for mass weapons of mass destruction, nerve gases were an offshoot of pesticide research back in the day, and they were organophosphate pesticides. You don't see them that often in EMS care, but when you do, the signs are pretty classic.
Yeah. And also, you think about the signs, we do have the mnemonic sludge and
Hmm.
something you want to be able to look for salivation, lacrimation, urination, defecation. It's like all the shins.
The
You-
patient weeps from everywhere. There is
Exactly. That's a
fluid
great way to
coming
put
from
it. Yeah.
everywhere.
And the treatment is very, very interesting. We talk about atropine, we need to be able to manage an aggressive airway.
Hmm.
And, the organophosphate, this is where you talk about having that nice shot of alcohol as well to
Yeah,
kind of help. We used to talk about that back in the old days, right?
yeah. And the thing is when we say, okay, you give atropine for anticolon or for cholinergic or organophosphate overdose, you don't realize how much atropine that is.
Yeah.
Most atropine, most what little 2-3 milligrams of atropine we carry for a code that's not even a dose of atropine for a cholinergic toxidrome. I remember back in the day, one of the first organophosphate overdoses we had it was the 4th of July, and they had a family gathering, a family reunion type of thing at this man's house. And the day before the thing, he had spread ant poison all around the yard. And there was just coated the yard with fire ant poison. You folks who don't live in the South, fire ants are a major problem. And the kids are out there playing in the yard barefoot on the slip and slide and everything else. And we had 4 people with organophosphate overdose. And we learned very quickly that, oh my God, we don't even have enough atropine on truck for one, much less 4.
Yeah.
So we started carrying atropine in 20 milligram vials for that very reason. And we had a few others over the years.
Yeah, I mean, and I think it's easy to happen. But let me ask you
Yeah.
this question though, because I think this is one that we really have to be able to think about. A lot of times, especially in cold and flu season now, we talked about getting tunnel vision. How does the cholinergic toxidrome differ from just a bad GI bug?
Because with a cholinergic toxicrome, a GI bug is not going to dehydrate you like a cholinergic toxidrome. You are going to be spewing from every pore. Like they said, salivation, lacrimation, urination, defecation, GI upset, emesis, meiosis, everything is
Yeah,
going to be weeping. You can't puke enough and have diarrhea enough to lose fluids like you would from a cholinergic toxidrome. It's just if you had to differentiate more of it and from more places.
yeah, that's a good way to put it. All right, number three is one of the favorites that we deal with all the time, the opioid toxidrome. Kelly, give us an overview.
Opioid toxidrome is CNS depression, pinpoint pupils, bradycardia. Would that every healthcare or public safety professional be able to understand and recognize an opioid toxidrome, and they would realize that 99% of the Narcan they're giving to their colleagues and themselves is for a hissy fit toxidrome and not an opioid overdose toxidrome. They are two very different presentations, and God knows too many people do not understand it.
Yeah, and also throw in there respiratory depression, and that's one of the
Oh
reasons that
yeah.
we give, Narcan for that. And we talk about Narcan, Kelly, back in the old days before electricity, our dose was zero point 0.4 to 2
Hmm.
milligrams of Narcan just so we could get the patient breathing again. And I think
Yeah.
we've gotten into a habit of pushing 2 milligrams in the house and waking the patient up and then getting an AMA and not taking them to the hospital.
Yeah.
Or we would give them just a little bit of Narcan, and as we were going through the door at the ER, we'd push the rest to wake them up so that the ER would have to deal with them. But what's the biggest mistake that new medics make when it comes to opioids?
Number one, Narcan is not a punishment. It's a treatment. You don't slam it. You bump it just a little bit, just enough to get them breathing again. All too many people, treat it like you're gonna try to block all the opiates in their system all in one fell swoop, and all that does is make you have to fight the patient. They're projectile vomiting. Sometimes they're in hypertensive crisis. Sometimes they're flash pulmonary edema, although that's fairly uncommon. Nothing good happens of just slamming a bunch of Narcan to someone. Now, I understand that with today, we have much more potent synthetic opiates out there. Fentanyl is found in just about everything, but it still doesn't make an opioid toxidrome look any different. And the treatment for it is still the same as good old-fashioned heroin. You give them Narcan and just bump it a little bit, enough to get them breathing again. My good friend Gary Saffer says that opiate addicts take heroin to induce a pleasant stupor. If they're pleasantly stuporous but still breathing effectively, it's not an overdose. It's just a dose. And that's what a lot of people think is, oh, well, wake them up. No, you're just trying to get them breathing, and then you can sleepwalk them to the stretcher and bump them with Narcan as you need to on the way to the hospital.
Yeah. So, one of the things that's interesting too, as well, is that we stopped taking these people to the hospital. It used to be when there's an overdose, we take them to the hospital.
Mm-hmm.
If there's going to be a change as well in their behavior, it's got to start at the hospital level, right? We're
Yeah,
leaving them at home. When we leave, what's the first thing they're going to do? They're probably going to shoot more of the medicine, and they're going to need more of it to get over the
yeah,
Narcan that we just gave them. And I think that that practice was really, really bad. But number four, sympathomimetic.
yeah.
Spell it if you want. I'll use it in a sentence. So sympathomimetic toxidrome. Kelly, what do you give them?
It's sedation, cooling, benzos. They say avoid beta blockers. In occasion, there are some beta blockers or combined beta and alpha blockers that are effective, but generally we don't carry those on an ambulance. But labetalol, for example, is a combined alpha and beta blocker. The reason that they tell you to avoid beta blockers, they're almost always beta 1 specific blockers, and they block a little bit of the vasodilation that occurs from beta 2 stimulus. And then you have unopposed alpha 1 stimulus, and the patient gets much more hypertensive. In my experience with sympathomimetic overdose, sedation is by far the best thing. I had a patient who overdosed on pseudoephedrine over the counter. He was back in the day when you could buy speed legally at convenience stores. He took up several packs of Speedos. Literally, the brand name was Speedos. And this guy had the craziest heart rate. He had a heart rate of like 260 and a blood pressure of 280 over 160.
Get out of here.
Yeah. And you talk about hanging from the ceiling. And I cut that in half with a dose of Valium. A big dose of Valium, pushed much faster than I wanted to, but we were in the middle of a rodeo at the time. I didn't get to give the controlled, slow push. But the Valium alone cut
Yeah.
that in half and made him easier to deal with. But the thing is with sympathomimetic toxidrome, these people, there's a whole host of harmful things that happen by running your engine at the red line for a prolonged period of time.
Right.
Seizures, seizures, cardiac arrhythmias, strokes, all this sort of thing. Not to mention, we've had patients with sympathomimetic overdose, crack, cocaine, and methamphetamine that had rhabdomyolysis.
Yeah.
But just because the constant fighting and working your muscles so much can cause rhabdo.
Hey, let me ask you this question though, because I
Yeah.
think this brings up a good point. What's the difference between sympathomimetic and anticholinergic overdose? Because they sound very similar.
The main thing is the sympathomimetic patients are diaphoretic. They kick in your fight or flight response, and you get sweaty along with that. The anticholinergic patients are going to be dry.
That's a
They're
good.
going to be they'll be dry and dehydrated.
Yeah. And remember, so this is a stimulant. This is cocaine. This is methamphetamine, MDMA, bath salts, as you mentioned, that we were able to get over the counter.
Yeah,
These are things that we want to be able to look at. All right, number five. So we're at the fifth one,
yeah.
is sedative hypnotic toxidrome. What do you give the listeners?
These patients typically have CNS depression, slurred speech, poor coordination, hypotension. Their pupils, on the other hand, are usually normal. These are the patients that overdose on their benzos. And God knows there are enough prescribed benzos out there now. It seems like everybody in the world is on Xanax. To my mind,
Are you
Xanax is a
seeing a lot
horrible
of that? Are you
drug.
seeing a lot of that?
Oh yeah. In
Okay.
Southwest Louisiana, it used to be pretty endemic. You saw that much more than opiates. People, the Golden Triangle in Southwest Louisiana and Southeast Texas, pain management clinics were just proliferating there, and you saw people that had 90-day supplies of Soma, Xanax, and Tramadol. And people were, that's the first time I'd ever heard of something called Soma shakes. You ever seen the Soma
No, I've
shakes?
not. No.
It's almost tardive dyskinesia. They're very slow to respond, and they have this slow tremor kind of thing. And that was from overdoses and abuse of those drugs. But we used to see a lot of those. We used to, my first service, we used to carry Romazicon as an antidote to benzo overdose.
I
It's
was going
not a
to
good
ask you.
idea.
I was
Huh?
going to ask you though. I mean, because we used to see that. Why don't we give that more often?
Because people take benzos for a reason. And what do we typically give benzos for, Chris?
Yeah.
Seizures. So you put someone in withdrawal by giving them Romazicon and they seize, what are you going to do now?
What are you going to give them?
Hope, pray. So generally, Romazicon reversal agents like that are used in the hospital setting to reverse sedation,
Yeah.
not to combat an overdose. In the case of pre-hospital abuse of sedatives and hypnotics, you just support their airways, support their fluid status, pressors if necessary, but usually airway support, ventilation, and IV fluids are going to do what you need them to
What you
do.
want to do? Yeah.
Yeah.
There are a couple. I mean, those are the top five, Kelly, that I think we wanted to cover. There are a couple other ones that we have to pay attention to. Certainly, serotonin syndrome, hallucinogenic
Yeah.
toxidrome, and and maybe I'll ask you this question: what's a telltale sign of serotonin syndrome versus stimulant overdose? You have an idea for the audience?
Myoclonus mainly. They're going to have neuromuscular hyperactivity with serotonin syndrome, altered mental status, autonomic instability, the blood pressure and heart rate and everything all over the place. But they'll have this clonus, this tremor or muscle twitches that are typical of serotonin syndrome.
Yeah.
And what kind of serotonin drugs do we have? We have your most of your modern antidepressants are SSRIs, selective serotonin reuptake inhibitors.
Right.
So they're very common in society these days. And overdose wise, they're much safer drugs. If there is a safe drug to overdose on, I think that's a contradiction in terms. But back in the days when your common antidepressants were tricyclic antidepressants, SSRIs and monoamine oxidase inhibitors and MDMA abuse drug, but the modern antidepressants are much safer, but people still can and do overdose on them.
Agreed.
And the tricyclics are not gone. I mean, monoamine oxidase inhibitors are less prevalent than they used to be, but tricyclics are still used for things like some people have restless leg syndrome and fibromyalgia and that sort of thing. And tricyclic antidepressants are often prescribed for those sorts of
Yeah.
things. So,
All right, let's put a bow on this. So, treatment priorities in the field. Kelly talked about it. Always secure the airway, support breathing, monitor circulation, use benzodiazepines for agitation and seizures, fluid for hypertension, cooling for hypothermia.
yeah.
We want to avoid some pitfalls. Don't guess on antidotes. Know your toxidromes. But let me ask you this question, Kelly. I think as we get to the end here, what's the biggest mistake we make with toxicology cases, with tox cases?
I think we assume that people are taking just one drug. Quite often, we have these patients who are overdosed that have, their tox screen at the hospital just says yes. They're on everything. And the thing is people don't understand how the interaction of those medications. I've had police officers that knew a person took a speedball who said, give him some Narcan. I was like, okay. So we're taking the one thing that's keeping him from kicking our butts and hanging from the ceiling and acting like King Kong. We're going to take that away with
Right.
Narcan. The main thing is antidotes are overrated. Supportive care. When you
Yeah.
think about even opioid overdose, what we should be doing first and foremost is ventilating people. You don't just give Narcan, stand back and give them the stare of life until they start breathing again. You ventilate. You provide symptomatic support because the antidotes have problems in and of themselves. And like gut decontamination, we don't give activated charcoal all that often in the field anymore for a reason.
Yeah,
Number
because it used to
one,
get everywhere.
yeah, it doesn't, there is no appreciable difference between activated charcoal and no activated charcoal as far as mortality rates. It does not save lives. And the side effects, you aspirate some activated charcoal, you got a problem. So mainly supportive care. If we get really aggressive with supportive care, we'll take care of the vast majority of toxidromes out there.
Agree.
But hey, that's what we think. What kind of drugs are in your area? What kind of treatments do you use for the drugs of abuse and the different overdoses you see? We'd like to hear your thoughts at the show at ems1.com. And for myself and co-host Dr. Chris Cebollero, thanks for tuning in to Inside EMS. We'll catch y'all next week.